Back to you, Elliot.
Thank you, Tuhin.
Yeah.
Thank you very much. I would like to take an opportunity to quickly introduce those who you see on the screen right now. So you just heard from Tuhin Mitra, who is my long-term friend and partner in organizing a variety of things, including this group, Data Science and Analytics West Michigan, as well as Big Data Ignite. That is Tuhin Mitra. Down at the bottom, if your screen is arranged like mine, you will see Thomas. Thomas, pronounce your last name for me, which I always forget. Guide, Thomas Guide. Okay. Yep. There are about 4 different ways that I always consider quickly pronouncing that, but Thomas Guide. Thomas is one of the organizers of Data Science and Analytics West Michigan. Thomas, good to see you. Thomas will be fielding questions via the Slack, and if you care to use I think there's a chat feature associated with YouTube Live too. Is that true, Thomas?
Yep. So anytime you guys got questions, just type it in the YouTube chat, or if you're on the Slack channel, put it in there, and I will ask those questions out loud so either Paul or Wendy can answer them during the presentation.
Thank you. And the Slack channel will also be available to follow up with the speakers after the conference. So Paul, I think that you have access to the Slack channel, and there may be questions that come in after the fact or questions you want to respond to more fully. Please feel free to do so. And with that, let me begin by introducing Paul Warner. So Paul and I have been friends for a long time, even longer, in fact, than Tuhin and I have been friends. It will come as a surprise to you, Tuhin, because Tuhin and I have been friends for 25 years, I believe. But Paul and I went to college together, and in fact, majored in math together at Hope College, and had some classes together, and we're fiercely competitive. But I have to acknowledge Paul's superiority in the area of math. Anyway, I've resented you for that for a long time, Paul, but I'm getting over it little by little.
Imagine being in class with Elliot setting the curve. I mean, give me a break.
Paul, I've known him as he has progressed through his career and has served in a number of project management positions at a number of high-profile companies in West Michigan. And I'll leave it to Paul to disclose those or not disclose those as you see fit. But Paul has an enormous amount of project management experience in the area of IT. I've heard Paul present, in fact, at the project managers project management. There's a professional association, and you presented there. And anyway, I was impressed. But Paul comes to us with a great deal of experience, and I look forward to hearing what he has to convey to us today about project management and overcoming obstacles in the area of healthcare, and particularly with regard to digital products in the area of healthcare. Paul is now with Augusto Health, also known as Augusto Digital, and feel free to tell us more about that during your presentation. I'll also quickly introduce Wendy Umbriac. Wendy works for the Michigan Health and Information Network, which is a nonprofit that serves the state of Michigan and provides an essential element of of commerce and healthcare information. Shall I say the transmission of healthcare information? So we all are familiar with electronic health records and large companies such as Epic that have mature, well-established, widely adopted healthcare record systems. They're used by hospitals, they're used by their affiliates, their business associates, they're used by pharmacies. And when your doctor or your hospital passes that information to your pharmacy, the Michigan Health Information Network is involved, although you've probably never heard of it. But Wendy does work for that organization, and we look forward to hearing a bit more about that and a bit more of the technical details in the context of your talk, Wendy. With that, I'll turn it over to Paul, and let's launch. Thank you, Paul.
Great, appreciate it. Thanks for the introduction. Let me see if I can go ahead and share my screen here, and then we can go ahead and get started. Let's see if I can get into... Too many warnings coming up here. Present. All right, are folks able to see my screen at this point?
I see it, Paul.
Yeah, great. Appreciate the introduction, Elliot. Agreed. In terms of my qualifications, I don't know if I have any. I'm definitely someone who's frequently wrong, but I do attempt to learn new things every day and continually learn. So I have worked for some large companies, Gordon Food Service and Meyer in West Michigan, and also spent a good portion of my career consulting. And right now we're just delivering a lot of really interesting digital products. So appreciate the introduction, Elliot. And, in terms of this talk today, it is a little bit, it's kind of industry specific. It's got a little bit more of a business flavor to it. I've looked at some of the past presentations here, and there's some very detailed analytics and technical information that is presented traditionally. And this, we're talking kind of an industry specific take on it. So I'm just coming at it a little bit from the high level. And there's really interesting data science and analytics that can be done in healthcare. But it's a little bit different. It's a little bit different beast when you get into healthcare. And there's some obstacles and barriers in the industry. And so I thought that might be worthwhile to talk about here to a group that's doing interesting, that might have the techniques and might know the science and data to it, but may not necessarily know some of the lay of the land that's out there. So that's kind of why I thought about this idea or this topic. I'm glad that you're willing to join. If you do have any questions, feel free at any time to kind of shoot them out to Thomas there in the Slack channel. And I'm going to be covering some general topics. And I mean, Wendy, who's going to be doing a little demo at the end, she could correct or answer any of these slides better than I could. She's a kind of a genius in healthcare, and I appreciate her being willing to participate. But I think I'm going to be giving some kind of subjective and business oriented content, and then we're going to get into a little more technical when Wendy is able to demonstrate some specific solutions and stuff. So I thought it might be nice to see some of these things in motion, or some. I think it's a good example what Wendy's going to show of how how to successfully make progress in these areas, and MiHIN is doing that. So anyhow, I guess I'll go ahead and get started. I think we've already talked about the introductions from that standpoint. Again, I think I am in the Slack channel, so feel free to, if you want to connect or anything, or you want to chat further. Always like to, kind of bend an ear or whatever. I know we're limited right now in some of the in-person and networking events, but I'll always love to talk about interesting problems. So anyhow, I'm just kind of bringing up this slide. I've done a lot of agile coaching and transformation, and there's kind of a retro format. And I just wanted to bring this up. I'm going to be talking about the healthcare and data science with several different perspectives. And there's kind of an overlying analogy here. If you look at like a sailboat, and there's like winds pushing that sailboat along. So we think of like this healthcare data analytics. And there's some things that are winds in our sails that are helping us. Like these are the things that are helping us, that are making life easier for us. They're making us move forward, and they're helping us. There's kind of this anchor here that's dragging. There's other things that are constraints and things that are dragging us down. There's also risks underlying that you don't see. So I'm going to be bringing up some of the things that are anchors, like some of the things that are holding us down, and some of the rocks that are down below the water I'm going to discuss. And then there's kind of this island or goals, like, hey, this is that beautiful city on the hill, or this is the goal or the panacea that we're trying to get to. So that's kind of the goal where we'd like to get to in terms of healthcare data analytics. I'll talk about that a little bit, and then cover some of the things that are either holding us back, helping us out, or that are kind of sharks in the water, so to speak. So I just kind of put this analogy here because I'm going to be covering several, different topics, and some of those topics are going to fall in these various categories. So anyhow, I'll just do the slide up here for the fun of it. So again, healthcare data analytics, there's just a really richness of data that's out there, and it's a really important field. This is just a graphic that shows, represents visually some connections between a database in healthcare, with 3,000 tables. Again, that's not uncommon. the complexity of data, transactions, doctors, nurses, diagnosis, observations, Internet of Things. I mean, think about a hospital. There's so many sensors. There's pulse meters. There's oxygen meters. There's all these different things. It's just a very, very rich fabric of data. So, I mean, the ideal, again, here's just another visualization of healthcare data. Again, I'm not going to get into the details. I didn't create this either, but I'm just using this as saying, hey, this is kind of that island or that goal to get to, that we'd love to be able to be doing this fantastic data analytics and data science on top of healthcare. And I guess when it comes down to it, there's two main reasons. And I guess if I talk about, again, that island or that goal, like what's the why in healthcare? Of course, there's two main reasons. One is cost. I mean, there's the financial motivation and things like that, right? Like improving healthcare. I mean, the United States spends more on healthcare than any other country on a per capita basis. Approximately 18% of the economy is spent on healthcare. That's, $3.6 trillion. And then another off-quoted statistic is that, 20 to 25% of healthcare spending is waste. So that's waste, $720 billion of waste. So there's a lot of opportunity out there to make things more efficient, more effective. And if we can bring down the cost of healthcare across the country and make it more efficient, then, we can make it more accessible to more people and hopefully do a better job. So that's kind of the, the dollars and cents way of looking at it. The other one is health itself, right? Better healthcare, better health outcomes. Living a healthier life, giving people, improving outcomes for people in terms of health, longevity, things like that. I mean, obviously, if we can improve healthcare, if we can come up with, do analytics that find cures for COVID or cures for cancer or other things. I mean, obviously, improving health and people's well-being is a huge thing. So, I mean, those are, kind of the two main drivers or the two main goals that we could, we would love to get there. And I kind of put this, again, controversial quote or statistic that you'll hear is that healthcare is the third leading cause of death in the United States. So again, talk about waste and things like that. I mean, there's mistakes and things like that within healthcare that impact people's lives and things. So again, improving healthcare. And just because we're talking analytics and statistics and visualizations too, I'm including this graph. And again, I'm not sure if you guys are seeing this little thing in my here. I just closed it. This shows just life expectancy. So just showing that, hey, like, look, healthcare is improving. Like if you just take like a very base metric of how long are people expected to live, in the last 100 years, I mean, look at these graphs going from an expectancy of 40 years, up to like above 80 years in some countries. And, those graphs are going in the right direction. They're not tapering off. They're not doing that. So who's to say that, with improved healthcare, there's not, quite a bit more ground to cover in terms of positive benefits. So I just thought that was kind of an interesting observation. And again, with some data to back it up. So that was good. Hey, like it's great to increase health or life expectancy. Just another graph of life expectancy. It's not equally distributed. Different countries have different life expectancies. So like improving healthcare, even if we're like, we can't imagine lifespans longer than 80 or healthcare that gets us, longer lives and things like that. You can see that there's, an uneven distribution around the world of healthcare. So, these improvements and these efficiencies could be beneficial today. There's a lot of work left to be done. And I mean, it's a pretty impactful thing to just think about what this graph actually means. And then I just have one more graph. Even in the United States or let's just say in Grand Rapids, this is Kent County life expectancy. This is interesting information, like life expectancy in healthcare varies wildly depending on where you live and that sort of thing. If you look at the center of this chart, there's a very dark green area here, and there's a little orange spot right next to it. I mean, that's East Grand Rapids and Wealthy Street. It's like by driving a mile down Wealthy Street, the life expectancy changes by over 17 years. So that's just literally right here in Kent County. So it's just showing there's a lot. I'm just talking about kind of that goal, and that there's a lot of work to be done, and it's a really interesting, kind of inspirational field to kind of try to tackle some of the barriers in. So. And again, we get back to some of the anchors and some of the problems that are out there in healthcare, right? Is like healthcare records. And again, healthcare has been around for a long time. And I mean, sure, people recognize this picture of file cabinets. You've been to, doctor's office before. The fax machine is a very, very common way still in healthcare. We're trying to kill it through electronic record exchange. The traditional way, people have these health records were locked away in cabinets with the colorful stickers on them and filed away. And there was limited access to data. Data was has been very hard traditionally to access and unlock. And so, the state of technology, I mean, I'm a little bit exaggerating here for a reaction, but it is true that there's been a lot of progress done, but there's a lot more progress still left to be done. So then when it comes to digital healthcare, there's terms, and again, just some definitions you may hear, EMR and EHR, electronic medical records and electronic health records. Those are two terms out there that you hear interchangeably sometimes. Technically, they're not the same, but the idea of digitizing the health records for the purpose of leveraging the economies of scale through digitization and the efficiencies gained through digital transformation. Technically, EMR was a more limiting term in the past. It was more like a patient chart being digitized. But your EHR, your electronic health record, is kind of the term that's come in more broader use now that represents all your health information, your entire health record, and it being digitized electronically for the purposes of exchange and treatment. And again, there's work and study that shows, the digitizing of health records and all that does improve, obviously, the two sides of those benefits, both the monetary and the quality of care and patient outcomes. So privacy, I was interested, Tuhin, you mentioned data privacy as being one. I mean, obviously, privacy is this huge, is a huge anchor or a huge obstacle in healthcare. It's something that's a lot more tangible, I'd say, in healthcare than almost any other industry. I've worked in highly regulated industries before, in the financial side and credit card processing and banks and financial institutions, but that kind of pales in comparison to healthcare records. Elliot, I know you're a lawyer and an attorney, so obviously you may be familiar with some of the laws too, but just the importance of, there's both the legal side and the consequences of keeping health information private are very great. And so that does act as a barrier for people doing innovation and a barrier for people exchanging the kind of data that could be helpful to innovate and collaborate. There's both the legal side and just the kind of the human side of it too. Private information, it's my data, it's nobody else's business. Some of that stuff can be very sensitive, regarding health records, even in terms of, could it affect your employment status, or, could it affect, your relationships, or just, lots of different things. So there's privacy is a huge topic of consideration. And I guess, again, by way of definitions, I think, like healthcare, like any other field, has its own set of acronyms, but there's so many in healthcare, I just almost can't help keeping introducing these here in this talk. But many of these you may have heard before, but PHI is what you'll hear, which stands for Protected Health Information. So any kind of data that you would have that includes personal health information and protected health information, you know, diagnosis, information about me, my birth date, my weight, my height, my blood pressure, my diagnosis, you know, all that kind of stuff would be protected health information. And then PII stands for personally identifiable information. So that's, it might not be health information, but it's enough to identify me. It's my social security number, it's my name, it's my address. It's that sort of thing. And both PHI and PII are protected legally, and there's a number of, and maybe Elliot, and I'm sure Wendy could give a better explanation than I'm about to. I'm flying the plane pretty high here at 100,000 feet, and we could bring it down. We could bring it down a lot closer to the runway if we had to get into more details here. So again, I'm just getting a little bit more into kind of the legal and legislative barriers. HIPAA, which many people have heard of, which stands for the Health Insurance Portability and Accountability Act, is kind of one of the main laws in the United States that governs the protection of this data, PHI and PII. So this law that was passed a number of years ago and has since been amended several times is what is, you know, when you talk about HIPAA and you go to the doctor's office and you sign your HIPAA forms, you might be used to saying, yeah, share this information. I'm willing to share this information with my wife, with my spouse, with my mom, with my primary care physician, whatever that is. You're just working on one portion of the privacy that surrounds your data. And I just kind of have this next bullet point here. There's a complex fabric of laws that include national laws like HIPAA and laws that vary state by state. So literally states have made their own particular interpretations of various laws, and they have made their own additional protections, sometimes that are above and beyond, sometimes in attempts to repeal back some of the protections and things like that. And obviously in this world now, it's gotten very political. So I just talked about HIPAA, which people are pretty familiar with, that governs your general health care information and the use beyond TPO, which is treatment, payment, or processing and operations, whatever. That's the basic use of healthcare of your information that's allowed. I just also want to just make people aware there's even additional layers of information that has more protected status. Like, for example, substance abuse and mental health information. Anything related to your substance abuse history, or if you're seeking treatment or counseling for substance abuse, and mental health information is even more protected. There's additional laws that protect that even more because it's even more sensitive. There's a stigma to it. And also people are worried that people are going to, you know, if you're an airplane pilot, you know, that has a substance abuse problem, you know, we want that person to seek help or seek health care and seek help for that problem and not be afraid that their employer is going to find out or someone's going to find out and they might lose their job because of that. So, you know, there's special protections for even more information that goes above and beyond general HIPAA, I would say. And just saying it out loud again here at the bottom here, legal concerns and fear of disclosure of PHI is one of the largest barriers of data science and analytics in healthcare. Another problem with healthcare data and some of the analytics is bias. You know, racial and ethnic bias in healthcare data can negatively impact health disparities for underserved populations. So again, that's something to think about, you know, as we have data scientists and we have people that are implementing algorithms and machine learning and all that stuff. You have to be very careful with how you're doing that and consider the data that you have. A really interesting book on that, I don't know if anyone's read it, is Weapons of Mass Destruction, a book by Kathy O'Neill. I'd recommend that for people that know the science side but want to think about the ethics side of some of the bias that can be in healthcare data. And I just want to, again, I don't know how, I'm sure you guys all know this more than I do, but I just want to mention survivor bias or selection bias. So, you know, some people have more access to healthcare than others, you know, and therefore there was more information and more data regarding those patients than there are of other patients, but you may not have a complete picture. If a young child has cancer, leukemia, if they're a minority or Black, Indigenous, person of color, they literally are going to have a lower chance of survival because there's not as much research and not as much data, and the treatments and everything like that are not as well tuned as they would be to, other populations. So it's something to think about. And again, I'll just mention, that survivor bias. I got the picture here of the plane, and again, this is kind of a famous story, and people have probably heard it in data science. But it's just like the idea of like doing analysis on planes that came back from like World War II to determine, where are they most vulnerable, or where should they add more armor and things like that. And you could do a study on that and come back, and your results would be completely wrong because you didn't consider all the planes that didn't come back, the planes that got shot down. So like, hey, if a bullet hit the, hit the gas tank or whatever, then that plane was going down. And so they were missing all that data because they didn't have the planes that were actually shot down. So anyhow, that's just a matter of, it's a topic of selection bias and survivorship bias. I'm not sure how I'm doing on time here. I'm just doing a time check. I'm getting on a roll here, so I'll have to make sure I bring it down to a landing here, and we can pass the baton over to Wendy at some point. But so with all the concerns with privacy in healthcare, it's hard to get good data for the analytics, right? That's a real challenge. There are some quality data sets that are available out there, in the public domain, healthdata.gov. There's, CDC and CMS, Centers for Medicare and Medicaid, that make some data available. And there's scientific research that's been done. A lot of this data has been de-identified. So you have, you've removed identifying pieces of information or attributes on that data. There is some risk there, especially now with the advances in analytics, that, even though you try to de-identify the data, that someone could work backwards or figure out, kind of deduce identifiable data from that de-identified data. So that's a risk. Another option is synthetic healthcare data, and that'll be an interesting topic. I'm sure Wendy can discuss that, synthetic healthcare data that's being used at MiHIN. So where you basically are generating or making up fake data that has no bearing to actual humans, and then you're using that to build and innovate and iterate on your systems. I might skip through this slide. Legacy thinking and processes. Again, it's like, hey, like things are, getting into some of the modern technology and modern way of thinking. Some organizations are behind the ball. Innovation, lean thinking, experimentation, and iteration. Again, this is more philosophical, and I'd be glad to talk and get on my soapbox around how to deliver software very quickly and high quality. But I don't want to go too far down that road here. But I'd be glad to chat if someone wants to. Cloud technology is another. I guess I'd say the cloud technology is a wind in our sails. There's some pretty amazing technology, and you guys know it now, that allows us to do some interesting things that we haven't been able to do for years. Some of the great unstructured data and schemaless databases and stuff, where you can just kind of dump a bunch of unstructured data together and then start drawing insights and conclusions from it. Obviously in the AI and machine learning technology that's out there today, and big data, even when you say big, the ability to process millions or billions of records is great in terms of allowing us to do things that we've never been able to do before, and that's really accelerating the benefits that are on the industry. When it comes to another huge barrier to meaningful data science and analytics, or getting like that really valuable data that gives you a full big picture, is this concept of interoperability. And I'm going to probably park on this barrier for a minute. And that's something that Wendy can help address too. But this idea of interoperability it's one thing to have your own bucket of data, or one pharmacy or one clinic might have data, but how do you get that full picture? How do you look at the, all the pharmacy, all the clinics, all the providers, or multiple health insurance companies? What if you changed insurance companies, when you switch jobs, has your data been left behind, like your 401k? So interoperability is a big challenge. So I'd say data silos and walled gardens. That's the way I describe a lot of the healthcare industry. Eliminate silos. So, I'd say healthcare is dominated by large vendors with proprietary systems. And Elliot was mentioning this before the call, but yeah, there's like Epic and Cerner, these big vendors that have like huge systems for hospitals and huge systems for payers. They're proprietary and they have all your data inside them. And to be honest, no offense, I don't know who's all on this call here. They don't have a lot of motivation necessarily to get that data out of there. The more they can lock in the data, or the more they have the data, means that someone's more reliant on them to continue to go to them for more services and things like that. So again, there's lots of kind of pockets of disparate pockets of data that's out there. And so to try to be the wind in the sails and kind of solve that problem of interoperability and the fact there's all these vendors with proprietary data sets and formats, to the rescue, I guess I'd say, or the superhero on this stuff is, healthcare data standards. And I guess I'm not sure how authoritatively I can speak on this, or, what kind of statements I want to make, but HL7 and FHIR is the futuristic kind of data standards that's getting a lot of adoption, a lot of buy-in in the marketplace to standardize the exchange of information. HL7 is the organization. FHIR is the name of the standard, FHIR. So you'll hear FHIR. Stands for Fast Healthcare Interoperability Resources. And what is it? All you data folks would love it. It's just a schema. It's basically a schema of JSON definitions for health records. And its goal is to provide a standard. Hey, here's a patient. A patient should consist of these fields: a first name, a last name, a date of birth, blah, blah, blah. Here's a patient. Here's a diagnosis. Here's a provider. Here's a medicine. Here's a prescription. Here's an appointment. Here's an observation. It's a very vast, they're trying to standardize what these resources or objects are. It's a very, this has been something that's being developed over years, and adoption in the industry has been being pushed and advanced over time. Some places people are being dragged along kicking and screaming. Other times people are leading the charge for adopting these standards. USCDI stands for United States Core Data for Interoperability. The government is starting to buy into this into the standardization and starting to weigh in with their opinion. And they have like Medicare and Medicaid is like basically the biggest insurance company in the United States. It's Medicare and Medicaid, right? So they can actually lead and set the market trend on some things, strangely enough, because of their size, from that standpoint. So I think these data standards and FHIR are very important. And if you're talking about doing data science or analytics across multiple organizations, you're going to want to look into this stuff. There's this concept of HL7 accelerators, which are just additional initiatives designed to push progress in specific areas of healthcare. I'm going to skip through this a little bit. I know I'm running a little bit long on time. Innovation. So again, there's work that's being done. There's conferences around interoperability in healthcare, trying to get people to connect. Hackathons, connectathons. different events where it's like, come one, come all. Let's use these open standards. Let's get everyone into a room and see what we can connect up and, kind of build some really innovative and cool solutions that maybe read across multiple providers using these standards. There's kind of a definition of information blocking, which is basically the practice of not sharing your data or limiting the exchange of data. I kind of included the definition here, but the reason why I wanted to include the definition is because information blocking is now illegal. So again, another thing, I guess we talk about sales and things that are helping push data science and analytics and healthcare forward. Now some of these things are being legislated and mandated. So there literally was a huge, and Wendy could speak on this, she's an expert on this, on the 21st Century Cures Act final rule drop, which was a big act of Congress that just passed March 10th of 2020. So it's hot off the presses. And it basically legislates the adoption of FHIR standards for interoperability, saying we need companies, providers, and payers to be using FHIR standards. And then the idea of consumers should have access to their own data, to their own healthcare information. So these laws are promoting consumer access to their own data. And there's parts in there that make information blocking illegal for insurance companies and certain healthcare vendors. So again, there's wins in the sales to help open up some of this data and free this data. Again, we have to keep privacy paramount, and there's protocols for that. But with some of these standards out here, we can do a lot more.
Hey, Paul.
Yeah.
Sorry to interrupt, but I just received an advisory from Hey, Paul.
Did it just drop the whole thing?
Yeah, I actually just received an advisory from Webex that they were pushing out some change, and and I guess it just dropped while I was trying to communicate that to you. So I'm gonna get you back on. Looks like they're back on at this point. So
we have the rest of the audience. It looks like we have Wendy too.
Yeah. So if you want to start presenting, go ahead.
Okay.
1 second. I'm just going to start it.
Yeah, just if you want to confirm, I don't know, I assume maybe people can hear us or maybe they can't.
Okay, I'm in. Yeah, people should be able to hear you now, Paul. Go ahead.
Okay. Well, hey, I think what I'm going to do now, and if that makes to you, before I go too much further, health information exchange, I want to pass the baton to Wendy Umbriac, who works with the Interoperability Institute, and she works, which is this subsidiary of the Michigan Health Information Network. And she's well qualified to give the entire presentation I just gave, as well as provide additional details. And I think I'll pass the baton to Wendy and maybe let her go from there. Thanks, appreciate everyone, and hopefully, Elliot and Tuhin, we still have most of the audience out there still, despite the little hiccup here with WebEx.
Yeah, we apologize. There was a little bit of a Webex hiccup that we had to deal with, but the stream is still intact. So um, I didn't see a breakage in the stream itself. So apologize to that for everyone. Thank you. Wendy, take it away.
Thank you very much, Paul. I appreciate it. As Paul was mentioning, HL7 or Health Level 7 is an international organization that promotes standards for the healthcare industry. Today, I'm going to talk a little bit more about the specific slice that Paul referred to, which is the specific slice that involves interoperability or healthcare information exchange. And in order to demonstrate this, I can get pretty technical or I can stay fairly high level. I've got some slides, but Paul had asked me to demonstrate our Interoperability Land sandbox. This sandbox contains all synthetic data. As Paul gave a nice lead in, there are a lot of concerns about PHI, protected health information. So when developers go to develop applications that promote interoperability or allowing patients to access their data, it can be important that they do that in an environment without protected health information. Interoperability Land is one such environment. There are others out that are publicly available that people can access. I've gone ahead and logged into Interoperability Land. And in my sandbox here, we see a whole network of providers, pharmacies, payers, or insurance companies, and, of course, the Michigan Health Information Network that exchanges data between them. So here what we have are various health systems that represent the electronic health record systems such as Epic, a couple different pharmacies, payers, also known as insurance companies, and Health Information Network. Each of these represents a FHIR server, Fast Healthcare Interoperability Resource Server, that can pass information. The exciting thing about FHIR, as opposed to more traditional HL7 document-based systems, is that, believe it or not, in today's world, we are primarily still passing documents back and forth. Your electronic health record, if it's being asked to pass to a specialist or you move to another state, for example, it's likely and could very well come inside an encrypted email as one enormous document that has to be parsed on the other end. As data scientists, I'm sure you can appreciate that most industries, unlike healthcare, have moved to more REST-based or queryable systems that allow you to get the portion of information you're actually interested in, rather than being shipped an encrypted email that is that has an entire document that has to be parsed inside of it. So let's just take a quick look inside one of the EHRs and talk about the kind of data that you might find inside. Many of you may use Postman. I do have a couple Postman queries, but just to show you how this works. So as Paul mentioned, you do have the option of JSON, XML. There are a couple other options, but JSON is the most common format. And then the FHIR R4 standard is the current one right now. What you'll find is that instead of one large document, you have the data broken up into resource categories. For example, procedures you may have undergone, appointments, etc., that you may have had, and so forth. Let's take a quick look at the patients themselves. This, of course, is a not Postman. I would normally use Postman. Most of you probably do. But anyway, this interface will give us a flavor of what it looks like. So here we have a whole number of patients sitting behind this FHIR server, and we can query information about each one. This returns every single one. As you can see, it contains information like phone numbers, gender, demographic information, address, et cetera, et cetera. Of course, this is all synthetic, so we don't have to worry about any PHI. So I could go on and on about the different types of queries and all of that. In fact, one of my colleagues put together actually kind of a nice little slide deck that talks about how to make queries to a fire server. I could spend a little bit more time on that. Here's some examples and so forth. We can query the patient. You can query, of course, by family name and so forth. I'm sure all of you as data scientists are familiar with various queries. Obviously, you can look online and find all the search parameter specifications for fire specifically that will allow you to narrow down what you're actually looking for. Search parameters and building queries, here's the URL right in the slide. What might be of a little bit more interest to close with is to capitalize on what Paul was talking about, that these various HL7 accelerator organizations focus on. And he listed several organizations. I will focus on 3 of them and give examples of the kinds of work that they do to give you a flavor rather than showing you how we can get, Sarah Thompson or whoever this is by that phone number. So first he mentioned Karen. Karen is an organization that advocates for patient access to their own data. They have successfully allowed the Center for Medicare and Medicaid Services, in other words, Medicaid beneficiaries, access to their claims and explanation of benefits data. That exists today for those types of beneficiaries. More recently, due to the federal regulation change that Paul referred to as part of the 21st Century Cures Act, this is now being mandated across the board and for more types of beneficiaries. And insurance companies across the United States are going to be asked to comply with making sure that their beneficiaries can receive claims and explanation of benefits data. So here is more about how you would authenticate to do that. But basically, there's a whole infrastructure that allows authorization through OAuth 2. It redirects back, gets an access token, and then uses the access token to talk to the fire servers in order to get the data that the person is authorized to receive from the data repository. So you would be able to authenticate as an individual patient and only pull the data that sits inside that repository that pertains to you. So I will move on now to talk about Davinci, which Paul mentioned. Davinci is a public-private partnership, and their main aim is to endorse payer interests, and that means insurance company interests. Insurance companies have a large interest in getting a hold of data that sits in provider spaces. It allows insurance companies to better be able to make their money by understanding how well the providers are giving care compared to the gold standard, for example, where mistakes are made, et cetera, how they can best carve out health policies for various demographics and so on. There's a large incentive from the payer perspective to get that data out of the providers. And there's a large incentive from the provider perspective not to let it go. But anyway, I chose this particular data flow. Davinci has several dozen of them. This is one because it's one that people can relate to. If you've ever been on the phone with multiple various organizations trying to get your prior authorization to go through so that you can see a specialist, what Davinci is advocating is an actual data flow that will allow a provider to request a prior authorization and provide the data automatically from their electronic health record system that the payer would need to approve it. And the payer, in turn, if they receive all the information they need, would be able to automatically approve it through a totally automatic system in a matter of seconds and get it back to the provider. Thus, hours and hours of phone calls saved. The last flow that I'll talk about is Gravity. Gravity advocates on behalf of population health. And the big buzzword in population health right now is called social determinants of health. And Paul started referring to this a little bit, where your zip code, for example, is a big social determinant of health. Where you live determines your life expectancy, for example. There are other social determinants, things like whether you smoke, your income, whether you live in a food desert, and so forth. So what Gravity is trying to do is put together some use cases. I'll briefly explain this one, that allow electronic health records and data flows to track social determinants of health. This is something that EHRs, Epic systems, and so forth have been very slow to adopt. So here we have a situation where in one of our use cases, the primary care provider sends a questionnaire to a patient in order to screen them for certain social determinants of health. That may be food insecurity, housing insecurity, or transportation insecurity, for example. Depending on how the patient responds to the questionnaire, when they come in for their visit next time, the primary care provider will look at the results of that questionnaire and be able to refer the patient to various community organizations that could assist with transportation, for example, food stamps, etc. And that would be tracked and referred out to those organizations. This is very future state. It happens in very few systems today. And lastly, as part of their use case, research organizations, with the patient's consent, can get a hold of their responses to these kinds of questionnaires and utilize that data for population health research. Be cognizant of the time. I will stop there and see if you have any questions.
Wendy, thank you so much for that, and Paul, thank you for a fine introduction. So I do have a question about these last two use cases, which strike me as efficient. That is to say, this ability for a provider or for a payer to automate requests to a provider, and also for a provider to automate the distribution of patient information to a third-party provider of ancillary services like support for housing or food or transportation and security. And I wonder about that. You said it's a future state, and I wonder what the obstacles are there. And specifically, I'm wondering if the necessity for a third party to qualify as a business associate is one of those obstacles. And if you could just speak more to the obstacles to implementing this future state, where there's much more ease in transferring or porting information from one organization to another. What are the obstacles, Wendy?
I would say in these two situations, well, specifically, for example, the Gravity situation, what you'll find is if you go into the industry is that population health in general is chronically underfunded. The types of folks we're talking about here are low income, and the types of organizations that serve them are also very low income. So in being able to import the type of technology that the organization would need to efficiently transfer this kind of information in a state-of-the-art way is challenging. it often relies on federal government dollars. And federal government dollars so far were mainly given to providers to get their electronic health record systems booted up. And we discussed earlier before the call, 2 years worth of funding for health information exchanges for each state to start exchanging that information. So in the case of gravity and social determinants of health, or most anything that is population health related, it can be difficult to find funding. What researchers are attempting to do at this time is show insurance companies, the ones who actually can provide funding, that they may be better off and end up paying fewer premiums if they address transportation insecurity, for example, and allow their patients to see their practitioner when they need to see their practitioner, rather than waiting and ending up in the emergency room later. So that is the thinking about how that part may become unlocked.
Some high stakes analytics being done there, right? Yeah.
Well, that's a very interesting question. I'd like to pursue that just a little bit further. So we have about 2 minutes left. And before I ask my final question, I want to make sure, is there anyone else who would like to ask a question? Tuhin, Thomas? Are there other questions we want to insert into the discussion here, or should I go ahead?
I have a quick question. This is actually going back to the beginning of the presentation when, Paul, you had up on the screen saying that 20 to 25% of healthcare or spending, I think it was like $700 or $800 billion wasted. Is that wasted because of inefficiencies of transferring data, or what? Or is it a combination of different things? Or do you know the reasons why that amount of money is being wasted?
Yeah, I would have to dig into that a little bit deeper to get all the causes of that. But yeah, definitely the inefficiencies, the manual processing that has to be done because of that, procedures that weren't needed, extra scans because you couldn't get the form that you needed. I mean, maybe Wendy could speak to that as well too, but yeah, I can't speak any more in depth to that.
The hope is that electronic health records would provide some relief from medical errors, which is a large portion of the cost that we're talking about, and also that interoperability would assist so that your healthcare information is where it is supposed to be at the time where you actually need it to be there. And today there are still many legal challenges that present themselves that prevent that from happening. There is a lot of information. Certainly in my master's classes, I've read tons of information about various theories on what could prevent some of that waste. And I would be more than happy to forward to Elliot after this presentation further reading if you would care to, if you would like to gain more information that way.
Yeah, and I'd also like to make that available to the members of Data Science and Analytics West Michigan, if that's okay. And if both of you could forward your slides or those that you don't mind sharing, I would like to publish those as well on our website. Are there others who have a question, Tuhin or Thomas, or can I finish it up with the final one?
We actually got 2 questions now from the audience.
Okay.
So one from Tyler. He's asking, is there any reliable data anonymizer services or technologies that MiHIN or other states' HINs employ that comply with FHIR?
Anonymizer, that's a very interesting word. We use the word de-identification, and there is a lot of debate about de-identification. Paul alluded to it at a very high level. And basically, the latest research papers that I read on the topic have to do with the fact that it seems that even with the government standards of what constitutes appropriate de-identification, apparently re-identification has been proven by academics to still be possible. There's a lot of debate in the community about what length you have to go to get true de-identification. The other half of that debate, though, revolves around, is anyone actually trying out there to re-identify people? And there was a very interesting study done that ironically indicated that the biggest swath or percentage of folks out there attempting to re-identify are actually academics trying to make a point.
That's amusing. Hey, Thomas, was there another question?
Yep. Another question. This is actually from another Thomas. He's asking you, Wendy, broadly, are there hospitals supporting or blocking this movement toward interoperability?
Oh, there is a mix. In my latest paper that I wrote just in May that Paul had the wonderful, what would you call it, that Paul was able to read. Basically, there are health systems that have absolutely come out against sharing their patient information with the latest regulations. The information that the hospital keeps, money, that's gold. They do not want to let it go. On the other hand, there have been some health systems that have embraced the idea that patients should have more and better electronic access to their information. So although at this point, Epic came out against the latest federal regulations, it seems like slowly but surely, due to the 21st Century Cure Act, we are moving towards a state where more people will have more of their information available to them. As Paul pointed out, there's a lot of nuance since laws do vary from state to state. New Hampshire is currently the only state in the union that tells patients that their healthcare data is actually owned by them. Everyone else argues about who actually owns the data and what they can do with it.
Well, that sounds like progress to me. Thomas, are there other questions from the audience?
Doesn't look like it.
Okay. MiHIN, questions?
No.
Okay.
Thank you.
Yeah. So we're past the end of our allotted time, and so I would like a kind of a quick response to a final question, and then we'll adjourn. And it's this: I think there's two perspectives on this. One is how do we overcome these obstacles societally? So this is a societal problem, and you've talked about some of the large scale macro issues that exist, and then there are also micro issues. That is to say, the individual's access to their own data, a researcher's access to this data. And I think maybe the researcher perspective is particularly relevant here. The other perspective that's particularly relevant is the consultant's access. So as a separate consultant, as a consultant who's working and wanting to do work in the healthcare industry, how do we overcome obstacles to sharing? And so what I want to know concisely from Paul and from Wendy is what's the next step to solving the macro problem, and what's the next step to solving the micro problem? If you can just tell us what needs to be done to improve the situation. And with that, we'll close. Paul, why don't you go first?
Those are really tough questions. I appreciate that, Elliot. You're always good at helping me to think. I mean, my initial response is I always feel like if you can look at the outcomes, that can generate, activity. If it comes down to saving lives or improving, patient outcomes, or, sometimes in the case of providers or payers, saving money, I think tying those tangible outcomes to the work that needs to be done can, either free up or motivate or inspire people to do the work that needs that heavy lifting. But it usually becomes, it's auxiliary or outside of maybe the business that they're doing today. So, I definitely think looking at the outcomes. I mean, analytics is a huge tool for that. Like Wendy was alluding to, like the research that's being done to prove that it's actually cheaper to give someone a ride to the hospital or to their doctor appointment. I think if you have the right information and data to prove your point, then you can implement some of these societal changes. I think that's at the highest level. I don't know. I'll pass it over to Wendy too, because I can ramble.
Sure. So I would say, based on what I have learned over the past couple of years, macro problems like this end up being solved when policy and special interests and money all align. And we are fortunate that in March, policy was passed to advance patient interests and allow more patient access to their data. I think we're going to see more of that going forward. Special interests are trying to fight that, but also the money has to be available. So they started by making insurance company information, such as claims and encounter data, more available. From a micro level, that gets nuanced because you have vulnerable populations, and there's a lot of data out there that talks about even if you give someone their healthcare data, that doesn't mean they can actually understand what you are telling them. What responsibility does the primary care provider have to put the data into an understandable format instead of one that is intended to be understood by doctors? So I would say that one of the bigger barriers on the micro level is following the research that's being done at IBM and various universities on making healthcare data more accessible. The idea is that you would target someone with a 5th grade learning level in order to get the majority of your patients to understand what their healthcare data actually means in order to take advantage of it.
Wow, those were really wonderful responses to that question. I just learned a lot in this whole presentation, and in a concentrated form in your last 120 seconds of response to that. So yeah, thank you. I guess what you've pointed out is that accessibility means more. It's more than a technical question. It's a question of presentation. And what Paul pointed out, I think insightfully, is that making progress in a societal problem like healthcare portability requires the right incentives. And Wendy said the same thing, really. It's when policy and money and special interests align. So that's fascinating insight into how to make progress on both a macro and a micro level. I thank you all, Paul, Wendy, Augusto Health, Augusto Digital, Michigan Health Information Network. Thanks to Thomas for fielding questions from the audience. Thank you to MiHIN for setting up the technical back end to make this all possible. And thanks to all of you who have attended. And if there's more conversation you would like to engage in with our presenters, feel free to do so over Slack. And I would ask for Paul at least to keep the Slack channel in view, perhaps for the next 24 hours. And with that, we're adjourned. Thanks again, and we'll see you next week. We have another talk by Colin Prather, and you can see the website for details on that. Thanks again, and good night.
Elliot, thank you so much. I appreciate it. The opportunity to...
You're quite welcome. It's a real pleasure to have you on, Wendy, and to you as well, Paul. Thank you again.
Thanks, appreciate it.
Thank you all.